Welcome, everyone. My name is Renee Garrett, and I'm your speech therapy PD podcast host for Brainstorms Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Just so you know, this episode contains discussions of intimate partner violence that may be distressing to some listeners. Tracie's joining Renee in a compassionate conversation to discuss how CSD professionals can contribute to awareness, healing, and advocacy. Here are the financial and non-financial disclosures. Tracie Bearden is the executive director of TBI Med SLP Inc. She receives an honorarium from Speech Therapy PD for her podcast guest appearance. She has no relevant non-financial relationships to disclose. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. As the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on speech therapy PD, I receive financial reimbursement. I am also an adjunct faculty instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the chat or the Q&A box and will be answered at the end of the presentation. Now, without further ado, we welcome our guest, Tracie Bearden, MS, CCC, SLP, CBIST. Tracie is a Denver-based speech-language pathologist and certified brain injury specialist trainer. She has over 14 years of experience working with patients who have survived brain injuries in acute care or intensive rehabilitation setting. She's the owner of TBI Med SLP, a nonprofit organization that provides brain injury education to the general public, speech language pathologists, and healthcare providers to improve patient outcomes and decrease the prevalence of TBI in the community. Thank you, Tracie. I'm so excited for this and so grateful to you for agreeing to talk about this conversation that, might be a little bit of a challenge for us both. So thank you for being here.
Absolutely. Thank you for having me, Renee.
Of course. It's nice to have you back. This is a repeat, you guys. This is a repeat.
I know. I'm
um,
so excited.
Yeah, me too. And thank you for the work that you do in our brain injury community. I know that that's a passion that you and I both share. And so I think it's really important to point that out that being a CBIST is another step above just, like I have my CBIS, but that's another step. And now we have this advanced training certification that we can get as a certified brain injury professional. So yeah, thank you for doing that because it's helpful for those of us who are trying to get more information about how we can be that person that is sought out for treating patients with brain injuries.
Absolutely.
So let's jump into kind of the background and more the statistics and research part of what we're going to talk about tonight. What can you tell us about domestic violence survivors and TBI as far as the research goes?
So it is estimated that 36% of domestic violence survivors sustain injuries to the head, neck, or face, or all of them. And what we know is that injuries to the head, neck, or face are likely going to result in at least a mild traumatic brain injury, or a concussion. And about 1 in 3 women experience domestic violence or intimate partner violence within their lifetime. So it's much more prevalent than people think it is. And, it might not look the same as what Law and Order shows you, but it's prevalent, and the cognitive symptoms that can follow a TBI, especially related to a domestic violence situation, is pretty debilitating.
Yeah, and I think that it's important to note that how the TBI can happen is just like with a lot of our patients. It can be
Mhm.
from a hit to the head. It can be from that coup contra coup injury, whether that comes from a hit, from being shaken, but also for some people, it's actually being strangled or choked. So
That's
I think,
right. Also, being thrown down or thrown down the stairs.
yeah, yeah, and it's relatable. I think because when we think about when we were oftentimes I feel like as clinicians we remove ourselves from our patients in some regard because it didn't happen to us, right? So we're thinking about, oh, they had a fall in the geriatric population, or they had a motor vehicle crash for the sort of the mainstream adults from 20 to 50, 55, and then for our teenage clients, and I don't see pediatrics, I don't think you do either, but for our teenagers, it's
Mhm.
typically an athletic related
Yep.
injury or a motor vehicle crash. They're learning how to drive, and I think again that a lot of people just remove themselves from that and don't think of intimate partner violence or domestic violence as being something that would cause the same sort of injury. So I think it's important to link those things together. I know for me, when I was a graduate student, I might have even been an undergrad, we had to get those observation hours. And one of the videos we watched was actually someone who was a survivor of domestic violence, or her husband had actually, I mean, I'm just going to be honest, he had actually cut her in her throat and she survived, but had a pretty severe traumatic brain injury that caused a lot of
That's
speech
awful.
issues. Yeah, and I think that's where this stems from for me, is that deep-rooted like, it was traumatic to watch that video as a student, but it was
Oh, I'm
deep-rooted. It
sure.
it it made me want to know that I had a role and I needed to be serious about that role, because we see these patients and some people would say, "Oh, I don't wanna be a part of this because it's too
Mhm.
hard for me," right, as a
Right.
clinician? Yeah. And so can we talk about that too? How we have to remove ourselves sometimes as the clinician?
Absolutely, because as clinicians, in order to be successful and protect ourselves from burnout, we have to have boundaries.
Mhm,
And these situations, the the components that make up the situation can be very traumatic within itself, the story within itself. And that is
mhm,
of no fault to the survivor or anything like that. But from my own personal experience, whose story is horrific, that is a lot. I mean, like, it was a lot for me. And I'm not like laughing at like that, but it's a lot to put on another person, you know what I mean? And
mhm.
so when we're a clinician and you're overwhelmed and it's a lot and it's not yours, permission to get out of your own way.
Mhm,
Sometimes it sometimes it's just too intense.
mhm,
And I say that as a survivor and a clinician because when I originally had my eye checked, it was by an optometrist. And if he had told me to go to the emergency room, which he should have done, my optic nerve likely wouldn't have gotten so bad. And so it's knowing what circumstances you're capable of being an advocate and your best self in.
yeah. No, and I think that's good because, again, we oftentimes will think of, "Oh, that's not gonna happen to me," or, "It's not gonna happen to someone I know," and the statistics prove that, like you mentioned, that it's much higher, I think, than we think. And when we're talking about
Mhm.
abuse in intimate relationships, it doesn't always have to just be physical assault. It can be the emotional component. It can be psychological as well, because emotions and psychological are connected but also different. And then also sexual coercion, where people are, it's much like our sex trafficking victims, where they're
Mhm.
almost in a sense bribed or coerced into this thing that
Yeah.
is attached to their self-esteem, their livelihood. There's a lot of components to that, and I think it's really challenging for us as clinicians to probably know all about that. But being a trauma informed educator, as I have am and have been, I think it's important for us to acknowledge that and be honest about it and be more careful about the ways that we approach these patients, because
Mhm.
it's so complex, and it's not easy for people to escape that cycle, right? Because it is a cycle oftentimes.
Yes, that's what I was just going to chime in and say. So my circumstance was not cyclical, but the first thing we can do as clinicians to improve our care with anyone, but especially survivors of domestic violence, is to not judge them, which you can, just about anybody can tell me that they don't. There is a little piece inside of you, and I know this, that slightly does. Maybe not
Mhm.
every single person in the world, but the majority. And you, it's none of your business why the person won't leave. In my experience as a domestic violence survivor, I was able to get away, but like the court even told me like it wasn't within my right for me to know where he was at, because we were both travel healthcare providers, and I was trying to not get an assignment by him. And yeah, it it was unbelievable, the amount of fear that I felt for not being attached to him, like not married to him. He didn't really know where I lived, and I didn't have a child with him. And I couldn't imagine how fearful you would be to leave someone who does something like someone did to me, when they have complete control over the roof over your head.
Mhm.
They have complete control over if you can put gas in your car, or if you have a child with them. So it's like, stop judging, because you don't know
Yeah, and I
that
think
person's situation.
it's definitely a shift in culture, because like you mentioned, that a lot of people do have this preconceived notion of, oh, you could have left, or oh, was this something you did that triggered? And that's just like deep seated, rooted in a lot of people. But
It's kind of like,
it makes,
oh, you're the girl this happened to, and it's like, what is that even supposed to mean?
yeah, yeah, almost like you were too pretty, or you dressed provocatively. We've heard all these stories in the media of, oh, you wore too short of a skirt. But even more far reaching than that is reaching into LGBTQ communities, where domestic violence is often prevalent. And
Yeah.
again, not generalizing in any way, stretch, or form, but being silenced because you were an attractive person, or you met someone and you were attracted to them, and we're all adults, and you decided that this was something that you wanted to be a part of, that turned horrifically different than just hanging out, or just having an intimate encounter, for lack of better words. It's almost like you decided that you wanted to do that, so maybe you deserved it, or maybe it was, you should have known better, and those are
Oh,
such horrible.
there are so many things that people say to you, and now looking back on it, because of the years and thousands of dollars I have invested in EMDR trauma therapy. Renee, you wouldn't believe some of the things people said to me. And so, I mean, even I was like, wow. And it takes a lot to make me say wow. And so, right along with what you're saying, I know that I'm not the only one that experienced it, but man, the people you experience it from, you don't expect. And it hurts the most because if you're aware that victim shaming is a thing, you know it as soon as you see it.
Mm-hmm.
And it's really too bad because had I not had access to all of these mental health resources, which not everybody is privileged enough to have, I don't know if I would have gotten past a lot of that.
Yeah.
And grown and been able to, for better or worse, use the circumstance to charge for the nonprofit that I run.
Yeah. I was just going to say and wasn't a question that we kind of pre-prep, but I was thinking about it. And, where were you in the development of TBI Med SLP when this happened? Was this a prior
This was
event?
prior to anything. When this happened, I didn't even know what an Insta SLP was. This was in 2018. I didn't even know like the Instagram speech therapy community existed until 2020, like the pandemic. So there was a 2-year difference. And so, no, it took me how many, like 4 years. Like, I mean, it took me years to be comfortable enough to share my story. And that's why TBI Med SLP took as long as it did, because it took so much. And I'm saying this just to be honest, it took so much mental work for my PTSD and everything for me to be comfortable with putting myself out there and knowing that there are people judging me, and I just can't care, and I shouldn't care. Like, that's kind of where I'm at now. Like, it's something that happened to me. It's not something that I did, but it's something that happened to me. And my story can make a difference. And so if you have a problem with that, I really don't know what to tell you. I'm really tired, and I don't care. I don't care that much. You're not my people, but good things happen to bad people, and bad things happen to good people. And people need to understand that. And they do by those of us who can to share our story.
Yeah. Well, and I think that's a good place to jump in to what happened. And, certainly if you feel like there's something that we need to stop or we don't need to delve into, I know that you've said nothing's off topic, you're transparent, but I don't want this to be something that is triggering for you. I just want you to share what you're comfortable sharing so that, like you've mentioned and you and I've talked about behind the scenes of, if we help one person, that's it for me too. So
Yes.
no,
Do
I
you
was
just
just
want me
gonna say,
to? Okay, I was
yeah,
like, you just want me to start going? Okay.
whatever
So
you're comfortable with.
in the summer of 2018, I moved across the country to be a travel speech therapist, like everybody with, common sense does in their 30s, leaves their job. But when I got there, I was in Southern California, and I had met my attacker on Bumble, but I had made it very clear that I did not want to date anyone. I had just moved across the country. That was the last thing I needed. But he was a male nurse, and so we got along pretty well. So we would, like, once in a while, like, go out for drinks and stuff like that. And then I moved assignments. So I was no longer in Southern California. I went to Northern California by Yosemite. and he had made plans to come meet up there to go to a Van Morrison concert in San Francisco. And so the weekend he came, we went to the concert, and then the next day I had to work, and I guess he had to have been drinking all day. I still will never know. But we went and met some of my friends and then ended up at a bar, and he got violent, intensely angry that I was having a conversation with a townie, a lovely conversation from what I remember, and kept screaming. And then from what I read in the police report, because after this happened, I never saw him again, I put my hand up to his mouth. I wasn't touching it though. And I said, "Shut up. You're making an ass out of yourself," is what I exactly said. And then the police report said he snapped and just started strangling me. The bar that it was happened in, he was called him into the police because he ran, but he called and turned himself in somewhere along the way. Somebody had to catch me up to speed on this because there is a period of time I don't remember. What I remember, the first thing I remember after that happening is being in my house with the police in it, telling me that they were arresting him and I didn't remember any of this. And so then what happened next? I slept for a little bit, got up, took my dog 4 hours away the next day for his vet specialist appointment, slept in the middle of the vet specialist's waiting room for like 4 hours because I did not sleep the night before, and drove back. And the next day is when my eye had all these broken blood vessels and I had cloudy vision. And I saw the optometrist. He said it was stress. That same day, I got a call from the advocate, Christine. I always forget what she's called because she was so irrelevant. And she had told me, like, after the arraignment happened, which I knew I was entitled to know that it had happened and something was already going wrong, but she wanted pictures of my eye. It was just the most intense day. And then from that point forward, it was never the same.
Well, and I think the really interesting part that, we talked about privately is that no one advocated for you to go to the hospital immediately, right? So it was like the
Right.
police
And
and
like,
they question you like you weren't a victim.
right. And they like, yes, very much so, like not trauma informed. And then they were finally like, "So do you need to get checked out?" But like, I was just hearing this strangling thing for the first time. If you've never experienced the onset of PTSD, it is intense. And I remember being like, no, like I felt fine. Well, I didn't feel fine, but like I could not problem solve. Like, and they were making it worse by being less trauma informed because they were asking these very direct questions in this very, what's a good word for it? Very cold tone, almost like every question. And for everybody watching, sometimes I smile when I talk about the past because it's a coping mechanism. It's not because I'm happy any of this happened. But it was almost like they were asking, like, mad at me, like asking me these questions like, "Well, are you sure?" And I'm like, "No, you've been telling me this information. I'm not telling you the information. I'm not sure." And it's just real wild. Granted,
So so you
oh, sorry, I was just going to say I was also in a very small, very conservative
yeah.
town in California.
Hmm. And you lost consciousness, correct?
Yeah, like I don't remember, probably like at least a minute before it happened, and I don't remember at least, I've always tried to remember how long it would have taken me to get home from that bar, and I want to say 15 minutes. So at least I don't remember. I obviously was not unconscious that whole time, but like that's like a strong indicator of how much was lost.
Yeah, and I think it's interesting because I don't even know that you know how you got home or who called what, or there's like you mentioned, and that's true for a lot of our patients, is that they have this gap in time, and it's almost like they're penalized, like, why don't you remember? But if anyone is trauma informed or works with brain injured patients, we know that when you're brain injured, your body or your brain is trying to keep your body alive. So the trauma response is not to recall, it's to activate those systems that keep you alive. And
That's
so for
right.
me as a professional, it's not unusual, but it's alarming to think of how just sort of, I don't, neglected isn't the word I'm looking for, but just dismissed. Dismissed is the word.
Mm-hmm.
Dismissed is what it was. And I think it's so scary and disheartening to think that this could be a colleague but also a patient.
I was going to mention through I have had the memory come back. And as my first trauma therapist said, a memory is a memory, whether or not it happened. That I took a cab of some sort home. So I don't know if that's my brain creating a memory to make myself feel safe. Do you know what I mean? Being able to have some
Mhm.
sort of closure over something. Or if that's a true, whatever it is, it satisfies what I need to keep everything just moving along. So, but yeah, and it's even scarier when you find out as the provider that the patient drove themselves.
Mhm. Yeah. Yeah. And it definitely totally happens. I think it's a good place to talk about and I knew someone was going to ask this question. So, what is EMDR therapy, just for people who
Oh,
don't?
okay. So I don't want to get them wrong. Eye desensitization, no, wait, eye movement desensitization reprocessing. So it's the type
Mhm.
of psychotherapy that uses bilateral movement and your eye movement to basically, and though this is not an exact definition, but basically uses these tools, and I use some other tools too, to bring up memories by tapping into your feelings of being triggered and being present with those traumatic memories so that you can desensitize to them using coping mechanisms, and then reprocessing so that you can almost replace that negative thought with a better thought to help, so it helps decrease the intensity and frequency of flashbacks is the point of it. And that's my biggest barrier, are flashbacks and intrusive images. So that's why I choose to do that therapy, because it is light years better than it was.
Yeah, and I've actually had patients who were active duty or are active duty military who do similar. They it's exactly what they do. Same thing. The people who have had TBI,
Yeah.
who have PTSD. How comfortable are you okay talking about like your specific injury so that people understand how you sort of got to the EMDR therapy?
Sure.
Because
Yeah. So it's actually kind of just pretty simple. So before I moved to California, a couple years prior to that, my dad had passed away. But before he passed away, Renee, sometimes I'm good at predicting when a mental health crisis is coming on. I was like, I better go into grief therapy. I was like, because this is going to be difficult.
Mhm.
And Nancy, my first therapist, she was always right. Always right. Like, if I ever wrote a book, it would be Nancy was always right. Nancy told me to go to Al Anon for my family. I mean, she kept telling me to do EMDR and all these other things, but I had a lot of noise back then. And then, so when the trauma happened, I knew that I needed to do a PTSD proven therapy, because I thought, I am so screwed. I thought, I am so screwed. That was the first thought I had, which is, so because of the grief counseling, everything, I talked to a therapist from St. Louis that I was still in contact with. And he was like, oh, you're absolutely right. Like, you're handling this, you're doing the right thing. And it took me a while to find Melissa, my first EMDR therapist, who I would not have made it through that year without her. It is a powerful, powerful tool. And so I think my experience in healthcare and my prior experience in therapy gave me the education that I knew that I needed to do something for my mental health because too many things had happened. And so then, of course, because I go into analysis paralysis, I went into trauma therapy, saw EMDR, thought, God, Nancy's right again. And then, of course, I had to read a few of the articles myself. But I was like, okay, this is it. Like, there were studies with veterans, you know what I mean? Like, I was like, okay, I'm going to try it. And then I realized how expensive it was. But you know what? Truly, it's been worth every penny. Granted, my baggage is a little more full than a lot of people's, but I think it could significantly benefit the traumatic brain injury population just from like different studies that I've read. I think it could really help improve cognition by kind of reprocessing some of those areas that can't quite make insight in or get to that point of openness to and that flexible thinking.
Mm-hmm.
It's at least worth a try. Totally got off topic of what you asked. Sorry.
No, but that speaks to the question about, looking at resources and ways that this can be treated, but specifically the injuries, because a lot of times for those of us who work with traumatic brain injury patients, a lot of it is cognitive tasks. Sometimes it's swallowing. A lot of our patients get
Mm-hmm.
trached and have voice issues as well, or it can be really multifaceted. But your injury was different than what I typically see in practice, and that's why I ask about it, because it's impactful for your career.
Yes. So my injury outside of PTSD is an optic nerve injury. And so I had a qualified medical professional assess me, and I truly did not show the signs and symptoms of like a cognitive signs and symptoms of a concussion. What I showed was signs and symptoms of PTSD. But as we know, the brain is a complex organ, and you don't have to have cognitive signs to have a concussion. And so when my eye was bloodshot and my vision was blurry, I had what was called traumatic iritis. So it's traumatic inflammation of your iris. And that is vision threatening, but it's just to the optic nerve. So it's basically your visual perceptual skills. So like depth perception, low contrast sensitivity, peripheral vision. I've just gotten so adjusted to some of these, it makes me, I have to actually think about it now. Photophobia, and what I mean that there's a condition, I can't remember what my doctor put down, but it's light evoked blindness. So like when you get that blindness from like the sun or a set of headlights, like you know how it temporarily blinds you? Well, like mine lasts like at least a second, which is much longer compared to the average person's, which is like a hundred thousandth of a
Millis.
second.
Yeah.
Exactly. And so my eye kept getting worse. And then over 6 weeks, like it was the size of, a nickel, like, and I was in so much pain, I was taping it shut because the pressure was the only thing that worked. And then a friend of mine who had worked at the Trauma One ER as a charge nurse finally said to me, and I was out in the middle of nowhere, California, and she was like, It's a 3.5 hour drive. But you have to go to the Stanford emergency room today. They're the only hospital that have an on-call neuro-ophthalmology team. And I was like, I'm not doing that. I'm not doing that. And she's like, you're going to do that. 'Cause she's like, I'm afraid you're going to lose your vision. And I was like, okay, I'll do that. And so I drove all the way there, found a sitter there for my dogs who was in law school, and like the nicest girl. She was like, take your time if they have to stay overnight. Like, I mean, just one of those beacons of light when you needed it the most. And I got in, they rushed me right on back. That neuro-ophthalmology team flew down. I mean, they had me like in a trauma bay. It was a very intense experience, especially alone. It's another thing. If you guys are seeing patients that don't have a lot of family or support, which I know family can sometimes be a lot, I want you to take into consideration like they've been through a traumatic event and they're doing it alone. Like that is not for the that's not for the weak. So they need us more support. And they told me that if like I hadn't came in that day, essentially, I would have lost my vision permanently.
Yeah.
And so then I saw just an ophthalmologist, the head of ophthalmology, which he was like, his name's Henry Kissler at Stanford. He's an outstanding individual and physician and trauma informed. And then I moved on to my neuro-ophthalmologist, Dr. Heather Moss at Stanford, who saved my life in so many different ways. I hope she will never know the impact she had on my life. But yeah, the MRI, we have MRI evidence and all that. And so, just like she said to me, oh gosh, I'm losing track of time. 5.5 years ago, 6.5 years ago, 5.5. When I said, what am I going to do? That I will adapt to the visual changes and manage my pain with a certain nerve med. And you know what? That's Renee. She wasn't wrong. That's exactly what has happened. So, when we're talking to patients about what to expect, I think we need to be realistic in what we can predict. She could predict that my injury was permanent because the myelin sheath on my optic nerve had decreased. And the optic nerve is the cranial nerve that does not regenerate myelin sheath. She could tell me that. I also already knew that. She used to say, I really don't love how much you know about the brain because you're in the notes before we even get to the visit. And I'm like, she worry about me.
Yeah. Well, and I think again we're in this unique position where we do have this knowledge and we do have this responsibility for education and counseling for patients, and that's for whatever reason hard for a lot of SLPs and audiologists to be in a space of counseling and maybe feeling like they're crossing a line. But me being an SLP who was a family member of a stroke survivor first, I always felt like it put me in a different space because our me as a family member, I felt like I didn't know enough, didn't get enough education. Certainly, our communities aren't educated on a lot of these things that we're talking about. And it makes it more important for me to shed light on these kinds of things because if you're one person that's experienced it, how many other people are there out there who are practicing as SLPs who have, or audiologists who have experienced not necessarily the same exact thing, but something similar or trauma from the past that's
Yeah.
impactful on the care that they provide. And it's sort of like this fight or flight in my mind of we're either going to empower ourselves to be this safe space for our patient, this counseling piece, or we're going to be like, you know what, I'm not. I'm going to leave that alone. I'm not going to touch that, and I'm not going to talk about depression, and I'm not going to talk about other mental health conditions that can be a result of these things that happen to the brain, whether it's a TBI patient or a stroke patient. And again, I think that's where you and I really connect on that, because it's such a real part of the thing that happens to the person that they didn't ask for, right? No one
That's
asked to have,
right.
yeah, no one asked for a stroke. No one asked for a TBI. You certainly don't ask to be the survivor of a domestic or intimate partner violence situation.
And nobody deserves it.
Yeah.
Like, you know, that's another thing is tell me that you've never had a patient tell you, well, I did something to deserve this. Like, and then you just sat there and said nothing. I always try, I've had patients say that to me or something to that degree. And I always, unsolicited advice or not, here it comes. I'm the first one to say, nothing you did caused the stroke. Like,
Yeah.
strokes can happen to anyone because it is not our job as providers to make people feel guilty or ashamed, especially for circumstances out of their control. You might be the only safe place that they have, and that is
Mhm.
invaluable, even if it's just for 30 minutes. And I'm going to tell you what, I've been a speech therapist for 15 years, well, in May, and
Me too.
I have heard some interesting, terrifying stories. And while I'm not saying you have to expose yourself to all of those things, I'm saying that it is incredibly important for good patient care to hold space for hard things that other people are going through.
Mhm.
You work
Yeah,
with people that are healing.
I think you brought up a really great point earlier too, of saying that, we need to take ourselves out of a space of judgment, because a lot of our TBI and some domestic violence survivors too are at risk for behaviors that are,
Hmm.
because of the things that have happened to them, are they're at higher risk for things like substance abuse, alcohol
Yep.
abuse, things like that. And yeah, and a lot of times it is a result of what they have experienced in their life, and it's not always just like, you don't get up one day and you're like, oh, I just want to do a lot of cocaine, or oh yeah, today's gonna be great. I'm just gonna go stab somebody in the park.
Right. You don't just go from like here to here in the same day. Like it is compounded over
Hmm.
time. And it is typically based off of our environment and what we've been exposed to. And that also, like, I'm not saying like you can blame anything and everything on your childhood, but like what you were exposed to, what your values are usually are pretty related to what you were raised for them to be. Like, trust me, like they're not, people will let you know. But, it's, I always say, like, if when I feel really miserable, like, look at my environment. And that means the people around me, the area I'm in, the places I go to, what's not jiving, sort of
Hmm.
thing. And, is the same can be said for patients that, have a higher risk of these additional crime. Like we need to be doing more to support them in the community too.
Hmm. Yes, agreed, 100%. Yeah, and I think that's why your work with TBI Med SLP to me is so important, because you're picking topics that aren't necessarily these cookie cutter, like, oh, this is TBI, looks like this, and there's so many people that have this, and it's just not a cookie cutter experience for our patients. And so I applaud you for doing that work, because it's really important for us as clinicians to continue to say, these are what the resources look like in your community. And we talked about this before, like our brain injury associations vary from state to state, and those
Mm-hmm.
advocacy efforts and those resources are not congruent across state lines for a lot of us. Like Virginia has a really great brain injury association, but I know
That's what
there's
you were
other.
saying. Yeah.
Yeah, and I think, you've mentioned some other. Well, go ahead and mention some other states, that because I know you've done this work to see who has really great resources.
Okay, just because I don't know them off the top of my head. The Brain Injury Association of Colorado is a good one. The Brain Injury Association of New York is another good one. Let me see here. Brain Injury Association of Pennsylvania.
Yes, yes, yes.
Uh,
I
And
know there
there's
was
lots of
another one
other
that.
good ones out there too. There's one more I was thinking of. Oh, the brain injury is, did I already say New York? I did say New York. Okay, that was the other one I was thinking of. But there are other good ones too. But those are ones that stick out and they're pretty. The Brain Injury Association of Delaware
Hmm.
is pretty good. But they also post a lot on their social media and they'll have like little webinars. So some of them are free, which is really
Yeah.
cool. So, yeah.
Well, and I think that's
And
good too,
then,
because clinicians can then access those, and they don't necessarily have to be a member. Sometimes
hmm
sometimes you do, but sometimes it's just
right.
subscriber. Like, you subscribe to their email list, and they'll send you
hmm
monthly emails of, like, I just got the one for Brain Injury Association of Virginia this morning,
Yep.
that talks about the upcoming things for February. Some of them are paid, some of them are free, some of them are low cost. But the bottom line is that it's typically not the same topic every month, which is why
Right.
it's important, because you're going to get access to a wide variety of topics, but also sometimes it's empowering you as a clinician on how to not only advocate but educate your patients. If you are a newer, even if you're a seasoned clinician, a lot of people don't work with TBI patients, or
hmm
especially intimate partner violence patients, and they don't know where to start. And so that kind of gives you a leg up on where to look for things, so that
hmm
you have that support. A lot of those organizations also have hotlines where you can call, or like information lines where you can call and say, "Hey,
Absolutely.
yeah," whether you're the victim, whether you're the advocate, whether you're the family member, you can call and say, "Hey, this happened, and I don't know what to do. What do I do?"
Yeah, like there's the domestic violence hotline. If you're a provider, you can Google it. You can text love is all one word to 22522 and they can, if there's a situation or you need help, or somebody needs help, and they have ways to like emergently exit their site and stuff like that. So I did want to make sure to mention that resource.
Yeah, and I kind of want to backtrack a little bit. So I know that you mentioned the memory loss initially. You mentioned the photophobia, and the more of the symptoms associated with the injury to your optic nerve. Was there anything else that was a symptom that either you weren't expecting, or just was like, what the
I went
heck?
into I went into a freeze, which I had never heard of, and it completely shut down my hunger signal
Oh,
for
wow.
years. Like I just wouldn't have the hunger signal. And so I had to be, well, at first I didn't realize it was happening. I wasn't paying attention because I was triggered. There was a lot of things going on. But then when I realized like how skinny I got, but I wasn't trying, if that makes sense. Like it
Hmm.
took a while for me and my doctor to figure out what had happened. Like I have had to make a conscious effort to um, set timers on my phone and make sure I always had like fig bars with me and things like that. And like even if I wasn't hungry, like I had to eat something. And so And that has been one of the hardest things to retrain. And
Yeah,
so
that's super.
when people say like a constant freeze really does mess with like your digestion, like your nervous system, like it's a real thing because I was a stress eater before. And that's how it came up with my doctor. I was like, I'm not eating like for stress. And he's like, oh, ha, ha, like kind of laughed at me. And I was like, no. And when I explained it, he's like, oh, he actually went, oh, you're in the freeze. I was like, what's that now? I got my edge on.
Well, and it's so interesting because I think it speaks to the damage that was sort of glossed over because of lack of medical care initially, but also like your trauma response and like your brain needs food to heal. We know that as holistic providers, we know that nutrition is such an integral part of healing for TBI and stroke survivors. And so that is
Yep.
just so what did you do? Did you go to a dietitian other than the setting the timers and all that? Did you have to go to any specialty care?
I would ask dietitians that I worked with at different travel placements. They had me try protein shakes. My shrink and my therapist both were like, this is not disordered eating. You know what I
Yeah,
mean? Like,
yeah.
and then now as I've progressed along in my EMDR journey, the hunger signal has come back some. It can be inconsistent. I know when I'm stressed because I don't get it, but like that's kind of been a kind of huge win for me because that you don't realize how important your bodily signals are to you until they don't work.
Well, yeah, and you want to be really technical about it. It's looking at how your amygdala is functioning, how your hippocampus is functioning, and we know that oftentimes those are areas that are kind of overlooked.
Yep.
When we're talking about our TBI patients, they're thinking a lot of times it's that prefrontal cortex, that frontal lobe, that executive function, but they're not looking at those inner structures that control these things that are vital functions, right? And
Right. Yeah.
it's kind of scary to think that it's like, oh, here, you just hit your head. Go home and take some Advil. You'll be good. Get
Just
some
walking them
rest.
off.
Get some rest because our
Get
TBI
some nap.
patients could just
Yeah.
go home and go to bed and it's fine. They sleep
Take a
regularly,
snooze.
right?
They'll feel fine.
Yeah, yeah. And again, I just think it's more that really great points: community education, holistic care, trauma informed care, making sure that we are WD 40ing that squeaky wheel, right? We want to make sure that we're
Absolutely.
that thing that kind of moves that wheel along so that we can help our patients not only advocate for themselves but empower their caregivers or their loved ones to also do that
Right.
because they don't no one knows where to start. And if we're the professionals who are working in the field and we don't know where to start and we don't know how to educate our communities or provide advocacy and resources, then it's such a good oh, not good. Good sounds terrible, but it is a real area of need that we need to be involved in, and we need to be shouting from the rooftops
Yes.
for our patients. And yeah, I think there's so many more people out there who hopefully haven't had the same experience or similar, but we know that they exist.
We do. We do. And it it sucks. There's no other word to use. I was trying to think of maybe a little nice fancier word, but it just sucks. And that's all there is to it.
Yeah, no, I agree, and I think again it always takes me back to that experience I had as a undergraduate student watching that video and thinking like,
Oh my gosh, I can't imagine what that was like.
well, it was when I went back to grad school, I was a grown adult with children, and that was my immediate thought was, oh my gosh, what about, I knew this lady had kids, and what happened to the
Right.
husband, and unfortunately the court system is not always, I think it's depending on where you
Renee.
live and what your access, it's going to be better in some places than others, but you can definitely speak to that far better than I can.
Exactly. There's no reason to sugarcoat it here. Have no expectations, and hopefully you'll be surprised, pleasantly surprised.
Do you want to end that in kind of like sharing what your
Yeah,
court
so I
advocacy
went
is like?
I went because my advocate did not to 14 out of the 16 court hearings. I had to advocate for my own criminal protective order. The judge didn't want him to lose his Second Amendment right. And he never showed up to any hearing. His lawyer just did. And the DA pulled me in her office maybe like 5 weeks before this was all over. This went on for a year. Um, and told me, even though we had Stanford medical evidence, my case was not important enough for her to take to trial. And when she said that with her whole chest. Yes, she did. And she meant it because she settled with him. No jail time, $500 fine. Still as a nurse.
That's
That's why I did
insane.
it. That's what I knew I wasn't going to change my circumstances, but I thought at least if I can prevent it from happening to someone else. But, you know,
That's insane. And I'm so sorry.
thank you for that. We can only control what we do.
Yeah. Well, and I think most of the things that we had, a couple people ask questions, but it was like, what was your website? So I just wrote that in the comments, and then
Okay.
um, I do want to read this comment because I think it's really important.
Okay.
Um, it's a two part. To me, the attacker should have been charged with attempted murder. The police need feedback education like this to have victims of violence checked by physicians ASAP. A million percent agree.
So
Same,
actually, this was the only county in California that did not sanction strangulation as attempted murder. So thank you for
nuts.
saying that. That's validating.
Yeah. Then the same person said, I'm irate on your behalf. Sincerely sorry you had experienced not only the attack, but also the lack of support immediately with follow up. Thank you for sharing your experiences with us so we are more alert for possible signs and symptoms of violence and to offer support and referrals.
Thank you.
And then someone else said there has got to be some lawyers that would jump on this to advocate for the victims. Oh, God.
So I'll explain this last part real quick. So since he turned himself in, the state takes over, so the district attorney, and so you don't get a say in it. And I could have pressed civil charges, but it wasn't like he hit me with a car. So, and he's a nurse, so no lawyer was going to take the time because that type of lawyer only makes money if you make money, because
Yeah.
we would have never seen the money from him because he's a nurse. So I mean, I could have tried, but my mental health said no.
Yeah. And like that was the thing for
And
you
most
that
people
took.
don't understand that. That's why I wanted to explain it.
Yeah, no, and I think it's a flaw in the system, but it's also the truth, and I think that that's super important to share because again, it goes back to, and not that anyone has done that in this conversation, but it goes back to victim shaming from people that are in your circle or maybe have an opinion about what you did or didn't
Mhm.
do, but they don't understand the ramifications of, this wasn't just like, oh, I didn't even try. It was more like the system is set up against you in that circumstance, and it would have cost you millions of dollars that you would have never seen to
Right.
pursue this, and for
Exactly.
what? for what costs for you personally and your mental health, like you mentioned. So I think that
Exactly.
it's a great, not a great thing, but it's a great point and a valid
Mhm.
point. And you already know how I feel. But I just truly, truly appreciate you being so willing to share the story, being raw, being vulnerable, answering questions that are not easy, even though it's been several years since this happened. It's still impactful for you in your life, and I really just appreciate you coming on and sharing all of that. So yeah.
Thank you so much for having me and giving me a platform to share my story.
Absolutely, absolutely, Tracy. It's always good to talk to you, and you you always have a space here with me, and I just appreciate the work that you're doing for advocacy for our TBI communities. Tracy, just thank you so much for sharing this space with us and for sharing your story.